How can doctors strike the balance between appropriately treating patients who have severe chronic pain and also being careful to avoid misuse and/or addiction?
Well, I think with respect to the last part of that question, avoiding opioid overuse and addiction, one of the things the Medical Society has done is to make this absolutely a top priority for our organization. In the last year, there has been nothing that the Medical Society has spent more time on and dedicated more resources to than trying to address this issue of prescription opioid abuse and the unintentional overdose deaths that follow, whether it be from prescription drugs or from street drugs. With respect to the part of the question about what can physicians do to balance, this is a pretty difficult area for us. What all of us who are practicing physicians understand is that one of the critical parts of our mission as physicians is to relieve pain and suffering. And we know that in the not too distant past, because of fear sometimes, frankly, on the part of some physicians about prescribing opioids, that there was a population of patients who needed to be relieved of pain and suffering, those who had end-of-life issues, those who had cancer pain, who were not always adequately being treated for their pain. So a concerted effort was made to help physicians do a better job with treating those patients and relieving their pain and suffering. For better or worse, that really laudable effort to better manage pain at end-of-life, cancer, et cetera, translated into a more general prescribing of opioids for other kinds of pain, for what's called chronic non-malignant pain. That means the kind of pain that many of you know patients to have, such as chronic diseases like fibromyalgia, or patients who have pain in their feet and their legs from nerve damage from chronic diseases like diabetes. And as you heard from Senator Markey earlier, there were some publications in the medical literature back a couple of decades ago that seemed to indicate that using opioids in that setting, when done under the right conditions with the right precautions, would not lead to excessive amounts of dependence or addiction. We've now learned that that's not exactly true, and as the pendulum swung way over towards more and more prescribing of opioids for this non-malignant pain, chronic pain condition, we saw that more and more individuals were falling prey to this really horrible disease called addiction. And I want to make clear that it's a disease. It's not a weakness of character. It's not a poor choice. It's a disease that's as chronic as diabetes or heart disease. And as Dr. Benson indicated, it needs to be approached with the same tools of chronic disease management that we use for those other conditions. So for physicians, what we need to do is carefully assess our patients before we prescribe opioids for them. There are tools that are available to physicians to assess a patient's risk of addiction. And if a patient is at low risk, one can probably make safe decisions about short-term and/or chronic use of opioids. But for that percentage of the population, and depending on the study, it may be as many as 13% of the population who have a predilection towards addiction, one needs to be very careful, if at all, to prescribe to that population of patients opioids and other highly addictive substances. To that end, what we've done is put a couple of different kinds of things into place so that we can accomplish that safe balance between relief of pain and avoiding addiction. We have published 6 months ago now, in response to meetings we had with the governor and other members of his administration, a set of prescribing guidelines for physicians across the Commonwealth. And in those guidelines, we talk about assessment of patients for risk, And if you do make a decision to prescribe opioids, to start with the lowest dose for the shortest period of time, and that if your acute prescribing begins to evolve into a more chronic state of prescribing, to constantly reevaluate and make sure that you and your patient are not going down a path that will really be counterproductive. We've made a tremendous amount of CME, continuing medical education material, available to physicians so that they can learn how to avoid getting caught in this conundrum. In fact, we've had, since we put that up in May, we've had 5,000 hits on our website of prescribers downloading that educational information. You heard earlier from Senator Markey his effort to want to try and have greater national rules and regulations around prescriber education. All of you should know that here in Massachusetts, we have had required education for physicians as part of their relicensure for quite a few years now. So physicians in Massachusetts have been getting, as a requirement of medical licensure, education about opioid prescribing. We support that, and we make that kind of education available for our members. And then very importantly, we have tried to get a message out to the public. Tom referred to this in his comments about safe prescribing and safe disposal of your medications. And you should understand that of the people who are abusing or misusing prescription opioids, somewhere between 70 to 80% of them are misusing prescription opioids that were not prescribed to them, but rather were prescribed to somebody else. So we are putting out a public service message to our patients and to the public in general that when you are prescribed opioids, make sure you store them safely so that your teenagers don't get into them. And when you're done with them, make sure you dispose of them. We're going to continue to try and get that message across while we at the same time work very closely with the governor, the secretary of HHS, the commissioner of the Department of Public Health on a number of initiatives. One of which, and I see the commissioner is here and she'll probably talk about this later, but the Medical Society has worked closely with the DPH to pull together the deans of the 4 medical schools here in Massachusetts to develop a very innovative and collaborative educational program for medical students who are at the front end of the educational pipeline. So although most of our effort at the Medical Society is directed to practicing physicians, we also have a responsibility for helping to educate those who are at the front end of that education about safe use of opioids and how to treat patients who fall into addiction. And we are going to move that right through the educational continuum from students to residents in training to practicing physicians.
Thank you very much, Dr. Grab. Dr. Tony Dodek from Blue Cross Blue Shield of Massachusetts. Could you tell us about the Blue Cross Blue Shield prescription plan medication safety program? How did the program come about, and what does it involve?
Thank you, Jim. Happy to share the results of our program. This issue first came to light at Blue Cross a little over 4 years ago. And I think that was really before there was widespread recognition about the problem and certainly the extent of the problem. And our interest resulted from a casual conversation I had with a pediatrician prior to one of our physician advisory councils. And this pediatrician related a story, which is now all too common, of a 17-year-old high school athlete who was a soccer player and broke his ankle, saw an orthopedist who treated him appropriately, but then gave him a month's worth of OxyContin to control his pain. And within a week or two, he developed an addiction to the OxyContin, and the pediatrician had to find some addiction services for him, which was not an easy task. So he said, you know, he had heard this more and more in the community, and he challenged Blue Cross to see if we could do anything to help. So as a result, we analyzed our claims from the previous 1 to 2 years. And I'm happy to say that most of the people who received an opioid prescription during that time were treated appropriately. The average length of the prescription was about 7 days. But there were a small proportion who either got prescriptions from multiple prescribers or who got excessive quantities of narcotics, and we targeted those folks. So we're a health plan of 2.8 million members, and a small percentage of 2.8 million is still a lot of people. And the claims demonstrated that there was close to 100,000 of our members who were getting narcotics either inappropriately or at dangerous levels. And I think the best way to think of this is to divide narcotics into two major categories. There's short-acting narcotics. The best examples of those are Percocet or Vicodin. And then long-acting narcotics, I think OxyContin is probably the most well-known of that category. And when we looked at our claims, 35,000 people received more than a 30-day supply of short-acting narcotics, which indicates that there probably is an issue there, because we're talking about a drug that's designed for acute pain episodes. So once you need something for more than 30 days, you're talking about a different type of pain. And then we looked at the long-acting narcotics, which you would expect people to have a long period of prescribing, because those should be used for people who have chronic pain. And we found about 10,000 people were receiving those prescriptions for less than 30 days. So another indication that something was awry with the prescribing practices. And then thirdly, we looked at the combination products. A lot of the narcotics are combined with Tylenol. And excessive daily quantities of Tylenol can lead to liver failure, even resulting to the extreme needing a liver transplant. And we found that 25,000 people per year were being prescribed excessive quantities of Tylenol. So as a result of this, we convened an advisory group. We reached out to addiction specialists, pain management specialists, patient advocates, primary care doctors, pharmacists. We talked to DPH, our good friends at the Medical Society, and came away with a program that has been very successful. The challenge was to make sure that patients that have chronic pain still have access to those pain medications that they need. But at the same time, we wanted to try to minimize the risk of addiction to our membership and also the risk of diversion. So we put in a policy for new starts only. We did not want to inconvenience anybody who was already being treated and may have a chronic pain condition. And we limited the short-acting narcotics to up to 15 days supply. So previously, doctors would usually write for 30 days and then a couple of refills, almost reflexively. And now this policy forced them just to do 15 days at a time. After the second 15-day prescription, a prescriber would have to ask for permission from the health plan to exceed that and to provide medical justification for why a longer duration was needed. And along with that, they had to attest that they had an informed consent conversation with the patient, that they implemented a treatment plan, and that there's a prescriber contract, which for the patient means that they're only going to accept prescriptions from one prescriber, and the doctor promises to be accessible nights, weekends, or at least have a plan to address the patient's needs during off hours. And then the other thing we did is we limited the amount of Tylenol that someone could get in one of those combination products to up to 4 grams per day. And we've been running prescriber reports so that if one prescriber was writing for a narcotic and didn't know that a second one was doing that, we sent reports to both prescribers to better coordinate the care and to help minimize excessive quantities. So it's been in place now for 3 years, and I'm happy to say it's been very successful. It actually exceeded my expectations when we started this. The short-acting prescription volume has gone down by 25%. The long-acting prescription volume has decreased by 50%. And we looked at the total number of doses post-implementation compared to prior to the program. 21 million doses fewer since this program's been implemented. That's 21 million doses that are not in circulation.